We are also going to start vaccinating children.
Vaccination of children will only be undertaken if parents accept their children to be vaccinated.
Jonah got vaccinated at school.
Samanya kontino mwana wange bagenda kumupima. Bwe bamukuba empiso, Jonah yatandikirawo enkya okuzimba.
I went to Chirudu Hospital and interviewed Jonah on his deathbed.
I
was trying to get the first-hand information.
Mwana n'atabuka n'atandika okusesema omusaayi.
Just wondering, what's killing Jonah?
Wangamba ekibumba kya Jonah kyafa, ensigo zaafa.
So we got to know about the details of the vaccination and the uptake 2 weeks after.
For even simple things such as doing a blood test, consent is required.
Jonathan died.
Investigating journalist.
Killing Jonah. This
You
Friday.
were born into a Christian family.
Yeah, a very strict one. We would pray every day.
So you were the church boy at school.
And I used to even preach to others, by the way, to come to Jesus Christ. I identify as female.
You are certain that you are a woman,
Yes,
even though you were born a man.
yes.
Something that is unorthodox in Christianity.
It's considered a sin. It's just the body parts that are male, but then everything else is female.
Do men hit on you?
Yeah, we do.
Really? Here in Kampala?
Yeah.
When you say that you are focusing on transitioning, what do you mean?
Boob jobs, there's nose jobs, getting a vagina.
It's possible to get a vagina.
Yeah,
And are you considering that?
yes. Having children is good.
Will you have kids?
Yes, I will have them.
How will you have kids?
What I know is I want to have kids.
You'll be their mom
Yes.
because you're a woman.
Yeah.
Yeah, yo, yeah. Man, I don't know what's today, man. Today I'm not feeling it.
Rock Boom, now in a new bottle with the same taste and same positive energy.
Yeah, I drop it like it's red hot. Shorty's coming back up.
Available in a flooded 20 ml PET bottle.
I just took a Rock Boom and I know it won't fly.
Rock Boom, feel the positive energy.
We are also going to start vaccinating children.
Vaccination of children will only be undertaken if parents accept their children to be vaccinated.
Jonah got vaccinated at school.
Samanya kontino mwana wange bagenda kumupima. Bwe bamukuba empiso, Jonah yatandikirawo enkya okuzimba.
I went to Chirudu Hospital and interviewed Jonah on his deathbed.
I
was trying to get the first-hand information.
Mwana n'atabuka n'atandika okusesema omusaayi.
Just wondering, what's killing Jonah?
Wangamba ekibumba kya Jonah kyafa, ensigo zaafa.
So we got to know about the details of the vaccination and the uptake 2 weeks after.
For even simple things such as doing a blood test, consent is required.
Jonathan died.
Investigating journalist.
Killing Jonah. This Friday on News 24/7.
Hello, good morning. Welcome to Viewpoint on News 24/7. My name is Daniel Lutaya. Today we are going to be talking about an issue that everybody is interested in, because everybody needs to be healthy. It is something that is in our constitution. We are meant to be healthy, and the government is meant to ensure that every Ugandan and every person in the territory of Uganda where our law works is healthy, and therefore everybody is interested to know about their health. My name is Daniel Lutaya, and on the show today I have Joan Kilande, the Health Policy Advocacy Program Manager at HEPS, which is the Coalition for Health Promotion and Social Development. She's also a member of the Uganda Coalition on Access to Essential Medicines. Good morning, and you're welcome, Joan. And then right next to her is Peter Echeru, the Program Coordinator for Advocacy at CEHAD, which is the Center for Health, Human Rights and Development. Good morning, and you're welcome, Peter.
Good morning, everyone, and it's a pleasure being here.
And to my right is Dr. Asaf Owamukama Eli, who is the former President of the Senior House Officers. Good morning, you're welcome, Doctor.
Good morning. Thank you. It's always a pleasure being around.
And lastly, but certainly not least, is our Isaac Kayonde, who is a mainstay here. You have him every Saturday. Isaac Kayonde is a political analyst and also an NRM mobilizer. Good morning, Isaac, and you're welcome.
Good morning, viewers. I'm humbled to be here and glad to see the other panelists who are experts in this field.
All right. Now, the question that we've asked to the public online is, how healthy is Uganda's health sector? And I want to start with Joan. How would you best answer that question with regards to the things that have been happening in the recent past?
Good morning, listeners. Again, just to re-echo, to say thank you for tuning in and listening in. By the name's Joan Kilande, and to this question, for me, being healthy means that my rights are upheld as a citizen of Uganda. By that, it would mean that the services that are meant to be at every point of care are fully available at any point that I need to access them. And I speak as a health consumer. I speak as an ordinary Ugandan. I speak on behalf of the citizens of Uganda. So despite of the interruptions that we have as a country, that should not have any impact on me as a citizen, as a health consumer when it comes to my health. It should not be compromised because of any operational factors that are ongoing, or in any interruptions that have been caused by the epidemic, pandemics, outbreaks that are ongoing at country level. The upper hand for me is the access to the service. By the time I access a health facility, I should be able to access every service that I'm entitled to as a citizen of Uganda. So with that said, the ongoing incidences, the interruptions that we have at country level speak volumes in terms of violating the right of the citizens of Uganda. I would speak more and say I would commend the government of Uganda for the efforts put in to really address the crisis that we have at hand of the persistent stockouts of essential medicines and health supplies. We know that there have been country efforts to really speak to the concern at hand. There have been emergency meetings led by the Ministry of Health with the key entities, Ministry of Health, meeting with finance, interministerial task forces have had engagements. We are very aware that civil society under the Coalition on Access to Essential Medicines, that there have been efforts to engage with implementing partners who are capable in supporting to address the current crisis at hand. But as all these are going on, we need to be aware that this crisis means treatment interruptions, it means resistance, it means treatment failure, and if I'm on antiretroviral, it would also mean resistance. It would also mean if I have missed my treatment for over 6 months, because we are aware that since November, there have been a stock out. There has been an emergency delivery in the last 2 weeks. We are in touch with the facilities as civil society, where we have presence, and we have been informed that the deliveries were made 2 weeks ago, but we also know that these are emergency responses. They have not worked in the previous years. These are emergency efforts that have not been sustainable. And what hurts more as civil society is that the government is not coming out to speak to the population, to inform us, what does this mean? Which guidance do you provide to us as people who have been on care, as health consumers? If I have been on my entry review and I have missed, for example, 5 months, what does this mean in terms of reinitiating me back onto care? Because we very well know there are comorbidities that come with such incidences, with such prolonged days of missing treatment. So we need answers as health consumers, we need answers as civil society, as the population, because we really know that we are entitled to these answers. And when we speak and provide the guidance, we shall feel part and parcel of the crisis in terms of managing it and sustaining and providing sustainable solutions. We shall speak more as we go on with this conversation, but that is my upper take on this. Thank you very much.
Quite the strong worded opening statement. I want Peter to also give us his opening statement with regards to how healthy is Uganda's health sector. You work in the health sector, advocacy about health mostly. Most times that I've interfaced with you, it is either to interview you about something to do with health. So you have some idea of what happens, and also because you do a lot of outreach programs, you have reached in many corners of this country that I believe I have not reached, even I as a journalist. So what how would you rate our health sector with regards to being healthy?
Thanks. Thank you very much, Daniel. In terms of rating, I think we still have a long way to go. As a country, we've made progress. If you look at, for example, the number of households that live within 5 kilometers of a health facility, over the years, we've made significant progress. We've done well in terms of establishing health facilities and health units. Our biggest challenge is on the functionality of these health units. And that's where we need to place a lot of emphasis as a country. So in terms of establishing structures, we are doing well as a country. The challenge is when it comes to functionalization, you're looking at things like human resources. You're looking at things like medicines. Do we have medicines in these health facilities? We are talking about, even for the few health workers that we have, are they within the health facilities at the times they're supposed to be there? So those are some of the challenges that we need to deal with. And you see, the biggest problem revolves around the money, the resource level that is available for the health sector. We have kept on flip-flopping between 6% of the national budget and 8%. And so this year you made good progress. You moved to 7.9% of the budget. Then the next year again you've dropped to 6.1. And so that frustrates this whole idea of progressive realization of the right to health. Because progressive means that as we grow, we should go, as the budget grows, we should also see a growth in terms of allocation to health. The World Health Organization recognizes that for you to start dreaming about having universal health coverage, you must allocate about 15% of the budget to health. And we are not saying let's wake up one morning and have 15% of the budget to health. But can we have a progressive program and say, okay, this year, even if we add 1% to what we had last year, progressively we move forward, because we appreciate that there are other priorities. But how do we move to that level? And that's where the biggest challenge is. We have a population that is growing at about 3.4. Then you have the same population having almost a stagnant budget. And I was looking at the budget specifically for health. Last year we had about 5.3. This year we are having 2023, 2024 we'll have again about 531 billion for medicines. So it doesn't add up, because the more children we have means that actually there is more need in the public health system. And our health system is so weird. The more younger population and the more older population is actually the one that uses public health facilities. The middle age, when you find from 20 to about 45, a majority of that bracket of population actually goes to private health facilities.
Because they have more money.
Yeah, they have more money, and some of them are on health insurance and all the things. So if we are having a growing population with a big bulk of young people, then if you want to protect them, then you must invest in that public health service. So we still need to take time and think about how do we invest in health so that these health facilities are functioning. We have them now closer to people. What is now key at this point is now to invest in functionality. Sometimes government invests a lot of money in buying equipment. And there is an Auditor General's report which shows that sometimes they were doing an audit in a US funded equipment project. And what it was looking at was that, what it found out was that sometimes we bought equipment in this country and we did not have a house to put the equipment. So for 3 years they are packed in a box somewhere in a health facility. In somewhere they have been established where they have fixed them. They don't have an official, a qualified person to manage them in that health facility. So again, they are fixed in a house, no one is using them. Where you find sometimes you have equipment, they are established, you have officers to manage them. When they break down, you don't have capacity to repair them. So you have an officer who is supposed to be using the equipment, but they are sitting because the equipment has broken down. And in some cases, it is broken down for 5 years. So you have an officer who is earning a salary for 5 years. What he does, he comes in the morning, he puts his jacket there, he moves around the health facility to show everyone that I am around, leaves the jacket on the chair, and goes to do private work. Because at the health facility doesn't have equipment to use, but he is on payroll.
Yeah.
So it is some of these leakages, both for drugs and then also on the side of equipment, that we need to address and also get more equipment. Of course, government has done a good job in one of the areas we've been fighting with government over has been on motivation, on wage, and then motivation of health workers. Now that one is sorted, and I think we will not hear a case of doctors.
I don't know if it has been so, but I've seen Asaf is taking notes, so let's wait to see what he will say about that.
It has been substantially addressed for, at least for now, we are on a better ground than where we were last year. So now we need to support them to do the work they do. That means getting them equipment, making sure we have drugs in health facilities. Actually, the impact of drugs is so weird. We were in Kapchora and went into a health facility and it looked like a ghost. There was no one in the health facility. So we entered in and there were nurses. We asked them, what's happening? They said, that is what happens when there are no drugs here. Everybody disappears. No one comes to a health facility to seek help.
I want to bring in Dr. Asaf. Dr. Asaf, Peter says the government has actually handled you people very well. And you should actually thank Peter, who has done a lot of advocacy. Yes, a lot of advocacy to make sure that you guys get paid. So I believe that the situation is okay in your regards. The good thing is that we have a health worker here who can tell us what is actually happening on the ground, because he's always in the hospital. So tell us, Dr. Asaf.
Thank you, Mr. Otaya. Good morning, viewers and listeners. I would want you to first allow me to throw some insight on really what health is, so that as we are analyzing, we look at the different domains that constitute health. Now, according to the WHO, the World Health Organization, health is not just absence of disease or infirmity. It is a state of mental, state of social, economic, and psychological well-being. So when we are looking at health, and as we are analyzing the different domains, we should be cognizant of that fact. Now, The health sector has also various components, but I would want also to aggregate it into three major ones. I look at human resource, I look at equipment and infrastructure, and those help us to give a service, so service delivery as the third major domain of the health sector. So now, reacting to what my fellow panelist has already said, yes, we appreciate the efforts that have been made by the government to address the aspect of motivation of health workers. Yes, we appreciate the fact that we've seen some incremental gains, especially in terms of remuneration. However, as we've been saying, it's not only salary that you need to be motivated. We need to talk about things like accommodation, for example, of the health workers. I'll give a scenario which he has already premeditated of the senior house officers who have laid for the past 4 years. Now, we have a scenario at the moment where doctors, these are full-fledged doctors who are licensed by the medical council, but they want to maybe gain more, they want to be specialists. But then the government is threatening to not pay them. Actually, they haven't been paid for the past 4 months.
Doctor, you should get close.
So for the past 4 months, are on the brink of being specialists. So now, if you create that sense of being unwanted, right? So once you transition and you become a specialist tomorrow, it would take a Herculean effort to again get remotivated and start performing, because at some point when you are training, people didn't show you any love. They throw you away. Now, so that's one of the areas that need to be addressed. Second, the issue of surprise and sundries. We have knowledge, but without those other things, we are Paris. I'm a surgeon. I can't work if I don't have a theater, if I don't have equipment to use, if I don't have personal protective equipment. Now, you realize that actually when we got when this most recent Ebola outbreak started, the first people to die were doctors, right, and other health workers, not probably the common man. Now, this shows you that actually we don't have enough personal protective equipment at any point. These things only come when we have an outbreak.
When something breaks out.
When something breaks out. Once we call it off, also the supply now goes down, we forget, right? We need a steady supply of those things. That's what we are talking about, right? So for us to get motivated, we must look at more than the remuneration. We must look at 360 degrees of our being. Now, I wanted also to give my submission on your first question about the state of the health in our country. And yes, we again appreciate the efforts that have been made by government. Really, it is crystal clear that a lot have changed in terms of, we have various indices that we track. The infant mortality rate, for example, has been reducing. The number of women who die out of preventable causes like bleeding during pregnancy has been going down. But of course, once we have spells like we have today, where we have shortages of, for example, drugs, where it puts us in a bottomless pit, which has a lot of ramifications, as one of the panelists has said. Now, we can talk about it casually, but if someone, for example, was to do an audit, a mortality audit, or a morbidity audit, suffering that has been caused by this, that's when we realize what it means to have a 5-month stock out of drugs. Then also, as I've already said, health has financial implications. Our forefathers, our ancestors were very wise. Actually, they used to tell us that you know, wealth actually is better than, health is better than wealth. So now, imagine we are talking about the days, for example, our patients stay in hospital for various ailments. Imagine a father who has the wife that has delivered, and because of the inefficiencies, the time they are supposed to spend in a hospital, for example, in 3 days, but because of the inefficiencies, they end up spending 2 weeks. Remember, this is the bread earner. Now, the fact that you are spending 2 weeks in hospital means you are not going to be making any income, and that has actually ramifications on the, you know, the financial state of the whole country. So we need to look at health broadly rather than focusing on disease and, you know, infirmity. Thank you very much.
All right, Mr. Kayonde, there is, you know, the governments all over the world are in charge of health. I think the COVID-19 pandemic really taught us that private health facilities are not the go-to when it comes to health. You have to deal with your own health systems internally as a government. And I've seen doctors strike, I've seen nurses go on strike, I've seen medical interns going on strike, I've seen teachers, public teachers going on strike. I've never seen government soldiers going on strike. Is it that they are more disciplined, or that government's priorities are elsewhere, in your opinion?
Thank you, Daniel. You know, this is a topic which is very political. Health internationally and everywhere is tied to the politics of the nation. When you talk about strikes, doctors and everything, you know, sometimes it borders political activism in a medical profession. So there's a question about the strikes that you see here and there. Sometimes it's not even a question of substance, but a thing of making political statements. Now, one of the things I find interesting is doctors who keep striking many are government-sponsored students.
Yes.
Government spends money to train them, right?
Yes.
However, these doctors strike to be paid to be trained. I don't know whether you get me. One of our health, a student who studies medicine in Uganda, when they go to Kenya, they don't do their mandatory 2 years of internship there because you have been trained in Uganda. I don't know how that system works, but that us who studied in the early 2000s know that that was the policy. We had many Kenyan students coming to Uganda to study in the medical field because they had an upper hand back home, right? Now, the thing is, the logic behind me choosing a profession to be trained in, at the point where I choose it, I should know, 1, what the benefits are for it, 2, the challenges I'll meet in it, 3, how much of my future is secured by that profession that I am doing. Nobody calls you to go and study the medicine. Get it? Sometimes it's a calling, sometimes it's who you have seen. Now, when you hold a government ransom every time for pay rise, I have a problem with it. You never had a strike in the 70s.
Maybe the government then was paying doctors well.
It was absolute. No. It was absolute. And it was absolute, and these challenges have been there. These doctors, you see, have gradually been, incrementally given money based on the circumstances. Back in the day, students, we are given boom, upkeep. As we used to call, they used to give us what they call faculty allowance. Faculty allowance was really an allowance for you to be around, but and the numbers now cannot sustain. The government which pays faculty allowance, my friend, now that to pay a generation to study. I have a problem with it, but probably it's international. I mean, maybe it's practice, maybe it's. But I think we need, as a government, to look into the issue of spending monies on paying students to train. Right? What we can do is guarantee them opportunity. That once you leave, again, we will pay you better. So you pay the professional who has gone through the training, pay them better, yeah. But this person who chooses to do this whole training should take responsibility for their
their training,
for their choices. I mean, for me, it's just a question of principle. But I could be wrong. I'm just saying I could be wrong, and I understand what they go through their training, right? But like I said, just like they stopped that whole boom and faculty allowance and everything, yeah, I think they need to review how people are trained. A person
do you think that the government of Uganda gives enough cares enough for the health sector? From the budgeting, from parliament, from all sectors of government, do you think that the government of Uganda really minds about how I get my Panadol when I fall sick at Chirudu?
Okay, so let me explain it from a political angle. I've let out my steam. That was my rant. First, we need to, when I ask people here, does Uganda have a healthcare system? Many people, especially opposition people or wherever, I've heard them, and they have clearly said Uganda has no healthcare system. But they even don't know the genesis of how we got here. Government, when it came into power, was contending with two issues: the issue of access and the issue of quality. Now, those two were discussed in the as an African issue at one of those African Union and discussion. I think it was in the early 2000s. I read about this in the African Review. There were 3 countries which were selected and 3 different systems. There was 1, Malawi, 2 was Uganda, and the 3rd was Rwanda. And there were 3 systems to follow. Rwanda chose the insurance, health insurance, to support their health system. The Malawi picked public-private partnerships as a way to deliver health to its citizens. Now, the 3rd one was Uganda, where we said it would be free healthcare for every person. Free healthcare. The president chose and said every citizen shall be given and provided for by the government of Uganda. So, you're not required as a citizen of Uganda to go to any government facility and you pay any money.
Now, I think they are taking notes, because now they are going to tell you how that system has either succeeded or failed.
As I make my you see, so that is
the health system.
The health system. That it is a free healthcare system. Now, whether people are going, corrupting people or doing what, that's another thing altogether. Whether it's working or not, that's another thing. But that was the intention. So the government of Uganda said, okay, how do we address the issue of quality and access? So they said, okay, fine. Access, we are going to build a health center at 5 kilometers from an individual. So they came up with a system. They came with, there was supposed to be a health center 1, health center 2, 3, 4, district hospital, and then referral. There were about 5, 6 stages, right? So what did they do? They said, okay, because that is the system that we have chosen to have access free, the donors said we shall buttress your proportion of health. We shall cushion it. That's how you see that the donors support, I think, probably about 70 to 60% of our health budget. So now they had that system. So they went on, what do you do? Let us construct these facilities. So to date, there are 3,650 healthcare facilities that are supplied by NMS. 3,650 health centers around the country.
Public health centers.
Public health centers. from the last person to the referral. 3,650. And they were all trying to address access. Now, because then the burden also became huge in terms of access, they said, okay, we eliminate Health Center 1. I think Health Center 1 was eliminated, and then they created VHTs, right? Village Health Teams. Now, that system runs. When we face epidemics in this country, we suffer very minimal losses. I can tell you Ebola went to Nigeria, an economy over, I don't know how many times the size of Uganda. It ravaged Nigeria, Ghana, and all those, you know. Here, Ebola comes, we lost how many? 50, 60? Yeah? That it shows you that the optics of it, us, the doctor, no, Uganda has nothing, you know, they go see the beds, see the thing. But there's something working, that we lose very few people when it comes. Look at HIV. What we used to contend with, for us who grew up in those difficult times, there's nobody in this country who grew up in the 90s who was not affected by a person, who didn't know a person with HIV. Rates were over 30% or whatever it is. Today they are in single digits. Single digits. South Africa, a bigger economy than us, with better health facilities, is struggling. So for me, it's an issue of understanding that what the government is doing is not mindless. It's not something that is out there and doesn't happen. So I was still telling you the two. As
you wind up, I want to give the opportunity to
final as I wonder the issue of quality in this country. Before, I think probably 90 something, we didn't have private hospitals, and probably many don't know. In the 80s, people went to government institutions and they paid some money. So what they did, government opened up to address the issue of quality. We said private people are free to set up private hospitals. Even I, as an entrepreneur, can go and set up a hospital. Yes, I'm not trained, I'm not anything. I set up a hospital and hire doctors. So it opened up for quality access. They allowed the private sector to join.
And then decided that the public should be zero quality.
No. The quality was that what do you do first?
Yes.
Do you build the hospital, and first of all, you even churn the quality, the training.
Yes.
We churn out so many doctors, so many as a country. We churn out so many doctors. Some unnecessarily, so many. On a graduation, I don't know how many graduate every year.
Close to more than 1,000.
More than 1,000.
Yes. Yes.
That's by no means there's no place. That goes, and there's no country around the region that is churning out the kind of numbers that we're churning out. Well, maybe you'll challenge me on that later, but it also depends on how the training. In Uganda, you can't teach medicine if you are not affiliated to a health facility. For example, I can't just go and start teaching like how you teach social sciences here in the building. I come and do. In Kenya, they do. Come and we train you nursing and whatever. But here today in Uganda, to become a medical doctor, you must be attached
to a health facility.
Those are some of the robust things that you do to maintain, to try and have quality. Our doctors are sought out. Go to South Africa, go to wherever. They are highly trained, they are good, they have good training.
Then what is failing? I want to bring in Joan. We've had the numbers, and Isaac makes the case for Uganda's health system, and he seems to disagree with you and say, we are okay. And he made a strong case, for the fact that Uganda's health system is okay and the health sector is fine. But the challenge is, I don't know why. If I went out there and sampled about 4 boda guys and asked them whether they agree with Mr. Kayonde, I don't think they would agree. and if I went and also sampled market people, the people who are supposed to consume this public health care, I don't know if they would agree. And if I found maybe 6 pregnant women waiting to deliver and gave them the option of delivering in a government hospital or for me to pay for them to deliver at a private hospital, I don't think that they would choose to deliver at a government facility. Why is that? That is just me thinking. Again, I could be wrong.
Thank you, Daniel, for thinking out loud and to all the ideas in the room. It's quite interesting. So for me, we are not saying the government has done nothing, but we are saying that
they've not done enough.
They haven't done enough, and the shifts are not sustainable. The shifts they're trying to attempt are not sustainable.
So in other words, the system you just explained is not sustainable.
It's not sustainable. For example, you started off, Doctor, by saying that we are heavily funded by the external funders.
Yeah. Yes.
We look at, I'll keep on linking it to the current crisis because that is the issue at hand. We have seen PEPFAR reducing the support to art. And one of the reasons they provide are valid because the initial agreements were, we support you at the effort that you also as a country increase your domestic resource fund towards art. So if you do not strike a balance, when year in, year out, there is no increment in the envelope, then that commitment ceases to stand. It would mean at any point if they completely pulled out, especially for art, we'll go back to nothing. It would mean that there will be a total crisis. So for me, heavy relying on external funding is not giving us a leeway to sustain the health financing system. When you also look at the reproductive health components, we know that without the Uganda Maternal Child Health Improvement Project, the AMCHIP funded under the GFF funding mechanism would actually also be in a crisis. This financing mechanism has proved to really be impactful, but when we're actually asking our civil society, because it has come to a close, what are you doing to sustain the results-based financing mechanism? What are the efforts? Because you're saying yes, when we pay per output, facilities actually deliver. But when we go ahead and interrogate and say, okay, look here, what are the next steps? What is in the pipeline to maintain this kind of mechanism of financing? The answers are not direct. We're not getting those answers and strategies from the key players within the government systems to say that we are making ABCD. We are really looking out for strategies to sustain. And again, the reliance is so much on the implementing partners, okay? Because it has demonstrated to be effective, so the suggestions are, look here, if a partner is willing to take on this, please support a region, support a district, which are all very key. But we need government to stand and say we can take on certain innovations that can be sustained within the government system. And when we also look at the efforts that we are making to push for the health insurance scheme, it's like we are getting a lot of, it has become political. And we know that for universal health coverage, like my colleague said, for financing, to have a financing reform for the health sector for Uganda, we truly need a health insurance scheme that is well built, but also very sustainable. So there are questions that have come out from the public. How is it going to work? And the Ministry of Health has labored to explain and say, let's push the bill to go through. The operational bits of how and when the scheme should operate will come in the operational document, which is a very beautiful also angle to take. But again, there is no effort to sensitize the public on what the scheme is about, because there's a lot of we are misunderstanding the whole purposes of having an insurance scheme as a country. So could there be deliberate effort for us to be sensitized as the public? When you talk about a health insurance scheme for a country, if Rwanda is working so well, What are they doing differently? What are those key lessons we can pick out?
Why don't we just copy and paste?
Exactly, because initially they also do the same. So for me, those shifts are necessary for both the financing reforms and also the operation of it. Let's not live in excuses, but really move forward. Even for the community health workers that we are talking about, the motivation for these village health teams, we also know that it's questionable. Okay, it's very questionable. Without implementing partners, we cease to see most of the VHTs operate at community level. So back again to my area of focus. When you also look at the issue of essential medicines, one of the strategies that Ministry of Health has proposed, because we've had a meeting between the civil society and the ministry, and they have told us, look here, we're also looking at ensuring that we lump cycles, because we know that the NMS, the National Medical Stores cycle, is bi-monthly, okay? But they're telling us, let us lump cycles, even for those that we have missed, to catch up with the missed cycles to also address the stockout crisis. But with the facilities we're engaging with, they're telling us, but that is a very good initiative. But look here, we do not have the storage capacity to take on more commodities for more than one cycle. Where are we going to keep them? There's going to be wastage. They're going to be expiries. Okay? So let's not look at handling an emergency with a solution that is also not very sustainable. Is it possible to have clear inventories, both bottom up, so that we address this issue, but also make it a sustainable solution? And we're also knowing that the core issue of this problem is also because of the consolidated fund, the integrated financial management system, which is also provided within the Public Finance Management Act of 2015, where the Ministry of Finance has directed that funds to NMS are paid through that consolidated arrangement. So this financing mechanism, as civil society and the community, we do not want to know the operational gaps, because we think that as players in the government system, we should be accessing these quality services despite of what is going on. They should be able to have controls within the system that should not even be known to the public. So basically, if they could work at the operational, address the operational challenges within the supply chain, address the political concerns between the different entities to ensure that the last mile deliveries are made and are also not impacting negatively on the service recipients at the point of care.
Peter, do you entirely agree with Isaac Kayonde and everybody who has spoken right after you spoke?
I usually say that the biggest challenge that we currently have is that a lot of policymakers and decision makers in this country actually are not beneficiaries of this public system. So you find a lot of people who are on health insurance and they do not actually understand what happens in this public health facilities. I was shocked to see the Prime Minister, I think it's somewhere in Uganda, visiting some health facilities. And she was so shocked to find that there were no drugs.
That there were no gloves and whatever.
People stealing some of the things that the government is sending. And then she visited Uganda Cancer Institute here in Uganda. And she found people lying all over the place. And she was like, oh no, we should not allow this to happen anymore. We must tackle cancer like we have tackled COVID. Everybody knows that Cancer Institute actually has improved.
So she found it improved even?
Yes. The situation there was so bad. But if the Prime Minister goes to a facility like that, and she seems to see news, it's a big problem. And so across, those who handle issues of money are people who actually do not go to these public facilities. So they do not appreciate the challenges that actually happen in these facilities. You were saying probably we go and copy and paste the public, the health insurance scheme from Rwanda.
Yes.
You know, when Rwanda was establishing that, we had already started conversations on health insurance. Because conversations on national health insurance have been on for over 20 years. And those people came here. Rwanda came here, went to the Ministry of Health, asked their opinions about some of the things. When they went back and they have established a robust public health insurance scheme that is delivering. I was actually told that in Tanzania, even the private health insurance services, some of them are actually closing because their system the public health insurance system has become so efficient that it is now competing with the private health insurance system. Of course, it doesn't take away the challenges of corruption, because I think they were doing an audit on their public health system, and they found men who had allegedly been admitted for antenatal. So those are some of the challenges that the system has. It will not be the magic bullet, but the World Health Organization recognizes that if you're talking about universal health, no government on its own will manage that if you do not adopt some sort of health insurance scheme. So it is one of the things that we think we need to invest in to ensure that public health facilities are able to run. But in terms of are we just not seeing the beauty in those health facilities? I think we have a huge challenge still. We need to continue to invest. Government has done a lot. We accept that. But we need to continuously invest in this area and see that those people who are supposed to get help, they are getting. You see, as a country, if you're looking at out-of-pocket expenditure, the money that you get from your pocket to pay for health services. In Uganda, we are at about 41%. And the strange thing is that it is continuously increasing every year. We were at 34 at some point. We are now at 41. That shows you that people are moving more away from public health service delivery into private health service delivery. World Health Organization says that once you cross the threshold of 20% as out-of-pocket expenditure, anything beyond 20%, you're beginning to push the community into poverty. Because now you'll find that once one episode of sickness hits a family, you're likely to push them now right below the poverty line because they have to invest in health care. So it is one thing that we need to invest. I always argue that if we do not fix the public health delivery system, we will continue to have challenges with other development programs. The likes of the parish development model
and the Myoga and everything.
And the Myoga. Because it is in our nature as human beings to preserve life.
Yes.
I will not let a child die while
I have my Operation Wealth Creation cow.
Yes, there. It will be the first thing I will sacrifice to save a life. So it is very important that as we think, and I'm happy that under the parish development model, there is a component on it on health. And the president has talked very nicely about how it is supposed to be, recruit staff to be based at Health Center 3 and all that. If some of those things actually come to life, we will actually deal with a bigger, the parish development model will actually contribute to us. If they actually implement it as the president is always saying.
Dr. Asaf, what Isaac said is similar to what President Museveni has said sometimes, and says you doctors are the ones that are failing government's plans to improve healthcare, because while government is planning, organizing, putting things into order, you just go out and strike. Then you run away. The other time we were contemplating of bringing Cuban doctors so that you people do not disorganize the plan. Yes.
Just a point of information.
Yes.
A Cuban doctor, I don't know, maybe until recently, was earning $200. A doctor, trained, right?
Yes.
The state would, of course, it's a Soviet state, they give you a house and everything. A Cuban doctor to come here and be paid $1,500, they are more than glad. The people we are talking about, who we are training,
our own doctors.
Our own doctors we are training. We are giving them what? How many dollars?
Maybe
more than
yes.
More than 300
yes. So they are earning more than the Cuban doctors.
More than a Cuban doctor.
Who is in Cuba? So if we bring them here,
the world, they say the Cuba has the best medical healthcare system. But a doctor is earning 200. You'll see what.
So in other words, what Isaac and President Museveni are saying is that it is not. It is inversely proportional. Paying you more does not make our healthcare system better.
I think Isaac is being diversionary here.
Yes.
First of all, in 2017, the Fountain of Honor categorically stated that because that time we had an issue where I would use this small group, the senior house officers, we were not being paid anything. He categorically stated that that amounts to modern day slavery. That was from his own mouth, right? Now, Isaac, if our clinical courts could allow us free access to goods and services in shopping malls, in hospitals, probably wouldn't be seeing these strikes. Now, why am I saying this? We have a situation, for example, I'll give the recent a COVID outbreak, because it taught us a lot of lessons. One of the lessons taught us actually that we can't even afford the services we offer. We had scenarios where, doctors were dying and they couldn't even afford ICUs. Now, I'll give an example of a pediatrician. I think you must have heard of that story where a pediatrician got COVID from somewhere in Guru, was airlifted to Kampala, but he couldn't access services which she has been offering.
The services she was offering, she could not afford.
Yes, because we don't have the money. We are poor. Now,
doctors are broke.
Yes. Isaac insinuates that strikes are always political statements. We put government on ransom. I think, Isaac, that's not the case. First of all, if you follow very well the dynamics of those strikes, normally the very last option, we normally engage government, right? And for example, this strike that is coming, we have a collective bargaining agreement that was signed by government on 21st of December 2021. That clearly stipulates that senior officers, the specialists to be, will be earning an allowance of 2.5 million shillings. This was okayed by the President of the Republic of Uganda. This was okayed by the Parliamentary Committee on Health. It is on record. These are not my words. You can go and check. Now, out of the blue, without any explanation, ministry stops paying the allowances. People work for 4 months, 5 months without getting any allowances. These people are not given any accommodation. How do you expect us to come motivated to work when we are not getting that? Now, I know you are going to bring the other element of health workers whose salaries were increased. Yes. We are not saying that government has done nothing. We are saying government is doing a lot, but it's not commensurate with the needs of the doctors and also the population. Now, normally when we strike, people tend to focus more on the remuneration bit of it. But if we check where the statements we issue out during those strikes, usually actually they are broad. We are talking about medicines and supplies. If you go and get a statement that was issued by Uganda Medical Association in 2021 during that industrial action, the first point that we wanted to be addressed was the issue of drugs in hospitals. If it had been addressed, we wouldn't be where we are today. So I don't want us to view doctors and health workers as selfish people who want incentives and then they run away. We are pushing for a system where we are given remuneration. And actually, when you check in the statements we've given out, we're even pushing for accountability from ourselves. We're not saying let's get money and run away. No. We've been very categorical that yes, we are getting those remunerations, but we must be accountable, right? And the government should address our demand 360. Let us have theaters in health intervals and district hospitals that are working. Let's have enough medicines and supplies and sundries in different facilities. Let's have accommodation for health workers, because sometimes when you talk about these things, we don't understand the ramifications of that. Now, sometimes we handle emergencies. God forbid if any of us got in an accident, for example, you go to a health facility and they tell you someone's going to travel 60 kilometers to come and attend to you. What are the implications of that? Now, so in a nutshell, government should not breach the collective bargaining agreements that we've signed. And when we are looking at those agreements, we should not only focus on the remuneration bit of it, we should view them 360. Now, the things when we're talking about remuneration, and when he's talking about training, he says government trains a lot of doctors.
Yes, on government scholarships for free.
For free.
Yes.
So the question
you are
is,
trained for free, so you give us some health care while you're training.
Now, they train doctors. Maybe let me first submit.
You want to be paid to study. That's what he said.
So what is the essence of paying for someone to study, and at the end of the day, you can't absorb them? We have a lot of doctors, by the way, out there. More than 7,000 doctors out there, but most of them are not employed anywhere. So what we are saying is, please, let's have a system that can absorb those doctors. When you check the statement that was issued by UMA during the last industrial action, that was one of the core areas we wanted to be addressed, right? Then the previous speakers talked about the health insurance scheme. I think we have, when you go in different facilities in the country, we have actually various local insurance schemes that are working, right? We need to benchmark and find out how those schemes are working. I think once we have a political will, what is missing is just a political will. Yeah, but yes, there's putting out an act or and you, just for formality, and you don't really go and implement what is in that act. So we need people who are really willing to implement what is in that act. I think it's something that is more realistic, and it's one of the magic bullets that can address most of the challenges we have in the sector. Okay,
let me bring in Isaac Kayonde now, before we go in for a break, I don't even know what to ask you, or what to respond, because now you have everything, all the government's, programs have even been put on the spot. Emyoga, PDM, they're not going to work if you don't deal with health. If I'm not healthy, I'm going to sell my Operation Wealth Creation cow to take care of my wife.
And Daniel, maybe as the doctor responds, we could also touch base with the unmatched doctor and health worker patient ratio, because the current staffing structure that was passed for improving human resources actually not being implemented.
Bottom line, why can't we just copy and paste? Rwanda is here, just next door.
And again, well, I want to answer many questions, but like I said, I'm not a government spokesperson.
Yes.
And I don't speak for government.
Yes.
And that was my disclaimer from the start. My venting was a moral question.
Yes, yes.
That if my fellow my colleague here was to go and train in USA for the specialty that he's talking about, he wouldn't spend less than $30,000 per semester in top.
Yes, the top hospitals.
They would spend. Some even go as far as $100,000 per annum for training. To be trained, you pay. It's the concept. Anyway, I'm not going to address this because the issue of is purely merely emotional. If I asked him how much rent do you pay for those senior quarters you stay in, How much rent?
Okay, first of all, I have to be categorical here that for specialist training, most of it is a private thing. People pay for their for tuition for themselves. Now, that doctor's village you are talking about, the accommodation.
Let me give Isaac his time. Take notes. Take notes. Let me give you more papers so you can write, because I see you have written so many notes. Your papers are full. Let me give you more.
Give me an answer quickly.
Let me protect Isaac. Write that down. You're going to tell it to us right after the break.
Then I want the last thing about these strikes, and I'll tell you this. You can gloss it all over. You get it? But it's a question of money. You know, in their MOUs with government, when they finish signing, which other aspect does government fulfill? Nothing. But once it fulfills the money thing, they go back and work. So, yes, you are going to put up a document, we want this. Yes, that's okay. Even me, I would not go and just say I want money. I'll do a write-up. But at the core of it, right, the basis really is just money.
But don't they deserve the money?
That's they look, and I've told you, yes, they could deserve the money because they go to the hospitals and they offer a service. But the service is not, it is the training that you see. You can't, as it's presumed that, look, if I'm going to treat a person, I better be there and learn how to treat. Just like you see us there, we cut rabbits and everything. Okay. It is the training. So it is the training. I'm offering you a service to become a doctor that you can use internationally. So there's this patient, work on him, you come and see. I have had the privilege of being treated in Mulago. If you go to the Heart Institute, in the morning, you have a senior doctor, a specialist, who comes with the students who are training. And he gives medicine, prescribes, finds out how you are, and teaches them. And asks, okay, so we gave him this, and this, and now what do you think? And they have a discussion around you. That is the training. So you don't come there and tell me that I need to pay you to make it because you made a choice. You get? I don't know how else to put it. But for me, like I said, I'm not government, and probably government has sought it wise to give them money. That's okay. That's it. There are other core fundamental issues I wanted to discuss about the healthcare. And I said earlier, I gave you a background to this healthcare system, that how the 3 different countries chose different things. Now Rwanda implemented the insurance. Now you see what people are, sometimes people get engrossed in big words. But back in the day, we used to have what you call cost sharing. So a person who went to Mulago paid the standard fee of 10,000. And that money would take care of the sundries. The things that Mulago would use. Okay? Then the president goes and says, no, we are doing free. You go to Mulago, you get free. This disease of free is what is the problem. What now you have from the doctors, or the general population, that one, there are 2 problems with government. One, government is poorly communicating. Poorly communicating. Is that even some of the things that they do, people don't know. People don't appreciate them because there's a problem. The general government is suffering from a trust issue. So the populace and the government, it's not working. It's not working. So until you address, like I told you, there are certain things people undermine, and in other societies, there's a large aspect of, say, teaching people patriotism. Now in the budgets they have put what you'd call mindset change, and I know many people were like, hey, but how do you give mindset change? But yes, it is a very important component to inculcate a mindset, even just for health. Just wash your hands. I ask myself, why didn't people die during COVID when people were not going to hospital? I asked a doctor friend of mine, said, look, he said, you know what? First of all, 3/4 of the diseases we treat here are hygiene
related.
So simple acts like wash your hands, in dusty times, cover your nose, would lessen the burden on our healthcare system tremendously.
By just informing people.
Now, healthcare, back to the health insurance. Health insurance, government wants to implement this health insurance. But there are certain fundamentals that must be before insurance. For example, citizenry. How are you going to know this is a citizen of Uganda?
We have national IDs.
This is the thing.
How do you know when you're giving me a passport?
When we got national IDs? 2014. Rwanda, Kenya had national IDs in the 90s. What I'm saying, there are certain things you must put in place to get this system together. Data collection, for example, about this person. You know, all those things must come into place. Now, the private healthcare insurance schemes are running, right? Those are for the rich in many ways. The ones which, those, and even in the United States, Obamacare versus what they had. It's different from the NHS in the UK. National health system in the UK is free for everyone. That's the thing we are taking. In the United States, they have medical insurance. Their insurance scheme, is private and government. That's why there was a whole debate about Obamacare. And even when Obamacare did what he did, he only added 20 million people to the register. You get it? So there are still people who are suffering with access. But that is a very technical area. And I'm telling you that for us to achieve a good healthcare system, we need to be able to have a clean and good
database
data system for our citizens, where people will know that this is it. In Rwanda, every citizen pays how much? How much? About 10? About 2,000 Rwandese francs, which is about 10,000
Uganda shillings.
Shillings, right? Is what every citizen pays.
Maybe it's political here. The government doesn't want citizens to pay because they will feel that, some type of way, politically, they would feel, some nice things have been thrown down by politics.
Operational areas can come in after the bill has been.
Now, to address her issue, the NMS drug stockouts, this is purely a system-based thing that they are struggling with, and it's a thing of NMS getting into that integrated financial management system. Before 2019, before this COVID thing, NMS was managing its own resources.
Yes.
Right? They have the accounts, they account for them and everything. So the problem now that they're grappling with is those cycles. That you see government releases money in quarters, right? NMS distribution is ongoing. It's a monthly thing that they have to distribute drugs. When drugs are finished, you make a requisition and all. Now, putting that system in tandem together is where the challenge is. I can understand NMS's position because say, okay, you're giving us money and everything, right? If you're giving us this money in quotas, even NMS
will supply in quotas.
It should be able to budget, plan
for that quarter, yes.
In quota cycles. But then there is the issue of disbursement in Ministry of Finance. So they put a limit. Once you put the law states that they must, in the first 10 days of a quarter, they must have disbursed. But the practice is that they release expenditure limits. So basically in the first 10 day of the month, they say, NMS, we come, all of you, this is the budget, right? Then the accounting officers enter into the system, right? And make requisitions, and then payments flow. So there is an issue there, right? Because how government works is that you put in the money comes, you say, you can spend 6 billion, right?
Yes.
NMS hasn't even consumed the money for the last quarter. You get it? So whose fault is it now? So the government says, you haven't even finished the money,
we give you, yes.
But the other ones are saying, look, you're not remitting the money. So there is an issue of how to manage this management system. There are efforts towards that. Unfortunately, it has turned out to be a national crisis in drug stockout because NMS doesn't have money. But you have to understand also that the wisdom of the leaders of an institution like NMS should be able to predict certain things. There's a component of purchasing of medicine. We only spend someone was talking about expenditure, our budget. And we are spending about about $32 per citizen in the health care system. $32, but the component of medicine is just like $3, right?
Yes.
So you find that all this money government is spending on health, putting up health facilities, buying equipment and everything, comes to this. It's the lowest, I think, in the region, but it is significant. It is not as petty as people make it.
That the government is not spending anything.
The government is not spending anything.
Okay, we'll go for a short break now. When we return, we'll continue discussing this issue of drug stockouts and if government is doing everything in its power, as the statements have said, to ensure that Ugandans can access quality healthcare in these public health facilities. Let's take a short break. We'll be right back.
My father, sir.
We are also going to start vaccinating children.
Vaccination of children will only be undertaken if parents accept their children to be vaccinated.
Jonah got vaccinated at school.
Samanyako nti n'omwana wange bagenda kumupima. Bwe bamukuba empiso, Jonah yatandikirawo enkya okuzimba.
I went to the hospital and interviewed Jonah on his deathbed. I was trying to get the first-hand information. Just wondering, what's killing Jonah?
We got to know about the movement of the vaccination and we are taking 2 weeks after.
For even simple things such as doing a blood test, consent is required.
Jonathan died.
Investigating journalist.
Killing Jonah. This fight.
Yeah. Yo. Yeah. Man, I don't know what's today, man. Today I'm not feeling it.
Rock Boom, now in a new bottle with the same taste and same positive energy.
Yeah, I drop it like it's red hot. Shorty's coming back up.
Available in a 20 ml PET bottle.
I just took a Rock Boom and I know it won't flop.
Rock Boom, feel the positive energy.
Emioga.
One of the best government intervention.
Meant to get Ugandans out of poverty.
How many people have paid back the money?
They really did not return their money.
Some people mismanaged their funds.
The leaders took much of the money.
Most of these people who are eating the money, they say they are cadres.
Some districts have not got any money.
A hit or a miss.
Emioga has not died in Soroti City.
She has died at birth.
This Friday on News 24/7.
welcome back. Good afternoon. We are live on News 24/7 with the show Viewpoint. My name is Daniel Lutaya. Today we are talking about the health sector. How healthy is Uganda's health sector? We've spoken about doctor strikes. We've spoken about the insurance policy that has never been passed by Parliament, but that some people think should be a part of our everyday healthcare system in this country. And now we are also live on Twitter Spaces, by the way. I would like to thank everybody who's joining us on Twitter. I can see Dr. Faith Nyabushao. I can see Joel Wetonyi, Musisi Derek. I can also see Mr. Twahirwa Bosco. Thank you very much for listening in. Hillary, Ida Bunya, many others. Karim is also listening to us. Kadu Deogracias is on here, and Mr. David Rukari. Now, you see, before we went into the break, we had a very heated discussion here, even off air. There was a very heated discussion here. I don't want to call it an argument because I'll get into problems. But these drug stockouts, there has been an explanation about the technicalities that are involved, and I just want to ask you, Joan, why don't you understand where the government is coming from? Because only last week you and Peter were in court suing the government over the drug stockouts, and yet, as Isaac says, they have tried to explain that it is not their fault. They are trying to work on it and everything that, Isaac has explained. So why have you failed to understand the government? Aren't you part of the people who are failing the government's efforts to failing government programs?
Well, they must account to their funders.
Yes. So thank you, Daniel, and thank you to the listeners and everyone in the room. So again, for me, as we started off, on the side of civil society, we really commend the effort the government is undertaking, but this has been on and on, because last year we had a similar crisis, and this was mainly for third act line, and the crisis was on for quite a long time, and you know how much this can negatively impact a person who is on life-saving drugs. It really means that if I'm not on my medication, then it means that my viral load will actually be unsuppressed, and it would mean I can transmit. Also means I can transmit through sex, or when I'm pregnant, or as a lactating mother. So basically, there are other implications, and these are very core and pertinent to us as civil society. As these political wars are going on between the different entities, which are very key and we know are critical to consolidate, we are saying, look here, people are dying, there are interruptions that are happening, there are adverse effects that are happening, and we cannot sit back and look as this is happening. We are demanding for answers as civil society, and again, we're just appealing to the government of Uganda to come out with explanations. As the crisis is happening, yes, you're providing emergency responses by providing a few deliveries here and there. We are aware that in the last 2 weeks, there are deliveries that have been made to different sites, and we appreciate that. But we are also aware that from July to December, there was one delivery. Now from this particular cycle also, there's still one delivery that has been made so far to these points of care. So this means these inconsistencies are becoming permanent. We are getting comfortable with the changes. And we also, just like Doctor has explained, it means we actually know where the problem is coming from. There is poor planning, inventory management. There is, I will not blame any entity at a go, because it's really, there is need to consolidate at national level between Ministry of Health, national medical stores at the central store, and then we also look at finance. If national medical stores needs to comply to the policy, and we really know that it's needed because they need to work within the government policies, let there be initiatives to support this entity to comply as required, so that this problem is resolved once and for all, than causing a crisis and yet people actually dying within the population. We are seeing people deteriorating. So let's have sustainable solutions. And again, we're also saying that even with the emergency deliveries that are being made, we're also seeing incomplete, suboptimal regimes being delivered to sites. So if I'm on a combination which is, let's say, third at line, and you just bring one combination, let's say a return over, it would mean that I'm not getting a complete combination. And again, it's not helpful. But in the meantime, you're not explaining to us as the public, if I have missed, how am I being supported? From a rights-based approach is what I'm speaking at. What can I do as an ordinary Ugandan who has missed treatment for a long time, and you're reinitiating me back on treatment without, let's say, for example, taking my viral load, and without using such results to inform the next steps of treatment? Are we providing this guidance to health facilities, or we are actually being just reinitiated onto care, and we are really facing the heat of some of these adverse effects? So I'm speaking on behalf of us, the service recipients, and we need explanations that are really basic, precise, and understandable on how to live within the crisis, but also stay healthy, and provide alternative solutions in addressing the crisis as this is being addressed at national level. Thank you, Daniel.
All right, Peter. Drug stockouts. Somebody on our YouTube asked and said, Mr. Peter Echeru, how far with the court case on drug stockouts? With 2 question marks. I just had to say that because there are 2, meaning they feel that their question is very tough. So I want you to answer it. How far with that court case? But also, why are you suing government instead of sitting on a table and discuss these things? You are failing government programs also.
You see, when we establish laws as a country, and one of the key principles in our constitution is that one of the rule of law. It means that we must act within what the law provides. And so, if you do not act within what the law says, then you're subject to be sued. Just like they say you should not steal, and then you're caught stealing.
If you steal, then you sue.
Yeah, the police will apprehend you and have you charged for those offenses. So just like the law provides obligations that the state has towards its people, including under the various laws, you know what the law under NMS Act says about the role of NMS in procuring and delivery of drugs. So we are simply asking court to remind everybody about the roles that they have to play in this process and create a benchmark upon which we will live. But overall, in terms, in as far as the discussion on stockouts is concerned, and I watched the minister's statement on the floor of parliament, and then the debate that happened, and it goes back to my earlier argument that a lot of times there are things that we do not take note of. A lot of times, people make it the way the media also has reported it, and the engagements in parliament, and making it appear like this has just happened, like it was news. What has only made this stockout unique is the fact that there was some sort of battle between government ministries, and that happened on the floor of parliament.
But it has happened before.
Drug stockouts are a normal phenomenon in this country. It is nothing new, and I'm sure the doctor will confirm that in most health facilities, for half of the year they don't have drugs.
Yes.
And I'm saying half in the sense that if, for example, they have supplied you for 2 months,
yeah,
you'll have drugs for between 2 weeks and 1 month.
I know someone on this table who will tell us what the situation is in Gomba, because he's always there. How it is there. But let him write.
So that is exactly where the problem is. That the problem is bigger than what we saw is actually it's just uncoordinated movement in government. What has currently happened, this one, It was a simple thing that the public finance management system closed and someone didn't have money to distribute drugs, but they had drugs in their store. But we have had drugs consistently. I was looking at, every year, National Medical Stores and Ministry of Health, in their mandate, do what is called the national quantification and needs analysis for medicines in this country every year as a basis for planning and informing government on what we need. And what that report says is that if you go to a health center too, the money that government is providing for drugs can only cater for 38% of the drug needs at health center 2 level. And that is the health facility that is closest to the community. It says next to that is health center 4. We are only getting about 52% of the drugs that are needed at that facility. If you look at sexual and reproductive health commodities, it's even worse. Over 30% is what we are providing in terms of resources. So it goes back to the problem of we are not putting in the money. That's one of the biggest problems. Of course, there are other challenges within the system. Supply chain challenges. The supply chain has problems. There are leakages in the system.
When you say leakages, you mean people are stealing the government drugs?
Are getting lost within the system.
They are not getting lost.
You remember?
I was part of an investigation called stealing from the sick.
That's exactly right.
They were not getting lost. People were disappearing them.
They find legs in the system.
Yes, they find legs and they disappear with the help of certain individuals.
So that system is leaking. Then there's the other problem that even when it is not leaking, we are using currently a dual approach. One is the pool system, where the health facility does its projections of what it needs and orders based on the projections from National Medical Stores. But also there is a modified push system that they have. Some people call it the district kit system, where now you have money at the district and the district must distribute it to health center 2s and health center 3s. Now that system for health center 2s and health center 3s is not doing well. And I've also seen a study from National Medical Stores which shows that if actually we migrated health center 2s and health center 3s to the system, to the pool system, we would substantially be able to effectively forecast the needs for medicines at health facilities 2 and 3. If you notice, you will go into one district, you will find that there are expiries in one health center 2 in the same district. But then there are shortages in another health center 2 in the same district. And the reason is that we are treating all health center 2s as the same. So you are sending drugs to health center 2s as health center 2s. They're all the same, but they have different demographics. They also have different health challenges in those health facilities. So what proactive health officers do is that once you've sent drugs, you keep monitoring and seeing where there are excesses and where there are shortages. And then you move drugs from one health facility to the other. But if you go to a district where, especially the smaller districts, where the health officials actually don't stay in the district, they stay in the nearby bigger district, or where they are not proactive to be able to monitor and shuffle drugs from one health facility to another. Then you find situations where you have drugs that are expiring, but then there's a facility that actually needs drugs within the same facility. So what needs to be done actually in that situation is to attempt to begin a serious conversation to migrate health center 2s and health center 3s also to the pool system. But you know what that means? That they must be able to access power. They must be able to access internet. You have a lot of health facilities that don't have that capacity. That you must be able to train health workers on how to order for drugs online. That there must be people who are able, because you're now migrating these ones into the system, there must be people who are going to check to ensure that were the projections done well and how was it done, to cross-check how the system works. All that needs you to invest money into.
And yet we don't want to invest.
But it's
we
part
want
of-
donor support.
It's
we
part of
can-
the challenges that we have, the supply chain system, but also the resource allocation that we have. Of course, these operational challenges between NMS, Ministry of Health, and Ministry of Finance, those are really things that can be. I actually find them so petty that as a country should really be able to handle them. And I think Ministry of Finance has guided very well. Have framework contracts. You know very well that on the 30th or 31st of June, the financial system will nationally block.
Yes.
You must have in place mechanisms through which to ensure that the drug
Services will continue.
And abated. I had a debate last weekend with someone who says that actually what you're seeing playing in public is not the real battle. There's a bigger battle which is behind the scenes. The things we are seeing is just a symptoms of a bigger battle. And that the frustration, the system is not being worked.
That there is some politics in
It's
there.
actually a frustration. Someone is frustrating the system so that
it is abandoned.
So that something happens behind the scenes and has
You see how politics comes in. And Isaac told us as political. But Dr. Asaf, on the ground, a lot has been said about the drug stockouts. But I just want you to explain to us what exactly is on the ground with regards to this. Because we might see statistics and data and papers, and I saw a court case and a lot of papers, but you're the one who is dealing with the patients on a daily. What do you tell a patient who comes into hospital and you have no tools to help them? What do you do, or what have you been doing?
Well, as already been said, the issue of drug stockouts really is we are just having an outbreak, an epidemic within an ongoing endemic predicament. So we've been having the issue of drug stockouts really is a chronic issue. And this is not the first time actually we are talking about it. I think 6 years ago still we are in the same outbreak. Then we went into endemicity, then now we're having another outbreak. Now, of course, I'm not the best person to tell you the situation all over the whole country. But of course from various reports it is crystal clear, that we are in a dire state. Now, of course, we've learned, I think, to tolerate a lot of inconsistencies and incompetencies. And, I think it's a high time we hold people who we've entrusted with power accountable. We have ministries that are supposed to handle this and plan, and we pay a lot of money, by the way, to those people to handle those systems, right? The way when you walk in a hospital sick, you expect me to treat you and you go back home, well, is what we should expect from those people, sincerely. Now, how do we go about those challenges we are facing? I think a lot has been said. Maybe my role is to summarize. I think I see it, the solution under 3 domains: managing the supply chain, managing the storage to avoid the leaks I've been talking about, and also managing the distribution. Now, we need to do a very honest root cause analysis, a very honest one. I think we should just avoid this scattergun policy, where basically we just come around during the crisis and we just want to attribute things that are not even well researched. I think we need to be honest and find out where the problem is in those 3 areas. Now, we are not the first country to experience this problem. About a couple of years ago, I think Kenya had the same problem. So they also in this hurabaru, systems, whatever. But actually, they later, when they did a serious and honest root cause analysis, they found out actually that the stumbling block was the bureaucracies within, the importation of drugs. So most drug, they were requiring each the importers to present a certificate of conformity then, and there was a very heavy fee that was attached to that certificate, and in the end actually it was hampering the supply of the drugs. Just one thing, I don't know what is happening in our country. Maybe the people in power should explain to us. So that's one of the things we need to look at in terms of supply. But also, I think we need, of course, we've talked about a budget allocation. Still, we must appreciate that we still
not giving enough money.
We are not giving really enough money.
There is a strike that is starting today. Your colleagues are striking. By the way, Isaac, while you were here talking about strikes, there is one starting right now as we speak for SHOs. What is it about this time?
So now,
still about money?
Yes, maybe the senior house officers, as I've already said, these are doctors who are training to be specialists. They are qualified. They have got practicing licenses. They are not students as we might want to portray it, as Isaac would want to portray it, as if these are people who are not qualified. They are just studying. They don't know what they know.
I use the word careful.
Yes,
Training.
yes. These are people who are qualified to be. These are doctors actually who just want to maybe to go an extra level. Now, these doctors, first of all, they pay to learn so that they get this service for free.
Yes.
They pay tuition to the different universities, and those who are under the fellowship program pay some fee to the respective authorities. Now, as I've already said, we had a collective bargaining agreement in 2021, 17th of December. Involved UMA and the government of Uganda, well signed. And they told us that they are going to give us 2.5 million as monthly stipend. Right? Now, out of the blue, they come and they haven't paid us for 4 months plus. And we've been engaging them. We've written to the relevant authorities. Please, we want to know what is happening. There is no explanation. So we've tried to engage them, but they are not forthcoming. So we wouldn't want to go into a strike, really. I think, if you know health workers and if you interacted with them, no one ever wants to go to. We are very calm and humble people. We wouldn't want to be in the limelight most of the times. We like to focus on our patient care.
On patients, yes.
But sometimes, as I've already said, a clinical court, doesn't guarantee you free services. In even our own hospitals, we have to pay for the services. We have families. We have to, we have to meet the needs of the families. Imagine spending 4 or 5 months. Remember, we work from like 24/7. Sometimes we don't have time even to go and farm. So we really give it our best. Now, someone spends 4 months without paying you. Tell me how they expect you to survive.
That is why you're striking today.
Yes, we've been pushed to the wall.
Isaac is holding the microphone before I give it to him. But let me read some comments from our online audience, and then I'll give Isaac the mic because it looks like he really wants that microphone right now. So let me not hinder Isaac from receiving the microphone. I think I'm going to ask the people on the Twitter space to also just go and comment on one of the posts on News 24/7 and ask your questions, because we won't be able to hear you back. Twitter spaces people would normally want to ask for the microphone so they can, but because of how we've because of the technicalities, we cannot hear them back. Now, here are the comments. There are quite many. I'll just sample a few. Moses Asimwe says Cuba is communist and therefore you don't need a lot of money to survive. There is completely free education, medical care, public transport, and many other things.
Thank you.
Dictor Asimwe says they want to have their cake and eat it. You run a capitalist economy where their doctors and patients spend lots of money to educate him or her, but the doctor cannot do the same for their children. Yes. Still, I hope you are. Okay, somebody's telling me. Lavia Pavani says, I hope you are not among the noisemakers in the media that were opposing the introduction of Cuban doctors. One of the weaknesses as Africans is we judge things with too much bias without thinking critically. Malak, you agree with the person against your host. I will refuse to give you the microphone. Okay, Malak Uganda, at Malak Uganda says, do Cuban hospitals look like this? He posts pictures of a mattress that is in a very bad condition and a bed without a mattress. You will go to Twitter and see it yourselves. Let me go. Okay, those are enough for Twitter. Let me go to YouTube. There are many questions. Nuahere Zamori says these are serious issues. Christine Akankwasa, good information. Those are good ones. Dorothy, Mr. Isaac, why do you always politicize government failures? Yes, opposition says that this country doesn't have a healthcare system in place. We wouldn't have been discussing drug stockouts if we had one. I hope you're writing. There is more. Papa Noah, the public needs to be in the know of this information. Anseb Sigan says, it is all about corruption in all government institutions. I think it would be difficult for Uganda to reach even the level of Kenya in health, for God and my country. That's his final ones. Then someone here says, why are those doctors who attend to us when we are sick not paid well? Pay the doctors. Simple. And they will work. What does it say about a government if most of our health budget is donor funded? What does it say about our priorities as a government? Because just imagine if we had if you had a government whose military and health budget and education budget are all donor funded. Is that even a government anymore?
Okay, thank you very much. First, I want to address that particular question. Why are we largely donor funded? And I told you from the start that this program, we are supported largely by these donors because of the system and healthcare system we chose to have. And it was a question of, do you buy a fridge, do you train a doctor and treat patients under a tree? Or you build the hospital, train the doctor, build the equipment, do all that stuff. But anyway, that's neither here or there. The issue is a lot has gone. A lot of the money we are spending for now has been into infrastructure of health service, of health facilities, a lot of it. And there are still gaps. And I did not come here to say that, look, government is doing such a beautiful and wonderful job, so there is more. We are the least contributors in terms of financing. We are at about $30 in our healthcare system. Kenya is at about $80 for their that goes per person into the healthcare system. Rwanda is at 50 something, 51. Tanzania at 40 something. So generally, the issue here we are dealing with is money. I can tell you, for example, these ones who are complaining about not being paid for 4 months.
Yes.
This country has been going through what you'd call inflationary tendencies. Inflation. And government has to fight inflation. Inflation is the number one disruptor of economies. Inflation. Now, they took a deliberate attempt to try and fight it and say, let's delay payments. In basic words, in basic economics, inflation is too much money chasing too few goods, that, very basic thing. They say, okay, let us delay payments as a method to control prices.
Yes.
Let's do this. I'd expect that government would communicate that to the doctors, right? To the teachers, to the soldiers. And all of them have suffered the same thing. Even teachers, Even teachers suffered about 3 months or 2 months.
Without salary. Because of fighting inflation.
Because of, yes, control spending. It's a tool, it's a fiscal tool, expenditure, it's a fiscal tool government has to control inflation. But anyway, I don't want to get into the economics. Ultimately, the discussion we should be having is just, you can talk about so many things about the healthcare, but it all comes down to money.
Yes.
It all comes down to money.
Which do we have, or do we not have as a country?
We don't absolutely have the money in terms of the collections that we collect. Today, in East Africa, we have the lowest debt, what do they call it? Tax to GDP in East Africa. Meaning that we collect a lot less
than our GDP.
Yeah, than our GDP, you know. So the idea is that, look, if you're going to look at this holistic thing, like Mr. Peter there said, the aspect of looking at the economy from a health perspective, and also the health looking at it from an economic perspective, to be able to say, okay, we are in this situation, right? How do we get out of it? The intricacies of the fights between NMS, Ministry of Health, Ministry of Finance, and everything, those are administrative. You should be able to handle them quickly, right? But the law is the law. The guidelines are the guidelines. People, you know, tomorrow, if Ministry of Finance released money and released it to people's accounts, you know, I mean, at the end of the day, it will come back to bite them. If the NMS goes and abuses this money and drugs are not. So, all these things, and I want to tell you that drug stockouts, even when you do, you who did the investigative story, it wasn't an issue of the drugs not being bought or the drugs not being distributed. It was an issue of theft.
Yes. Doctors were stealing them.
Yes, doctors were stealing them, right?
I think we need to be clear here. Not, they weren't. I think doctors, you know, the challenge is everyone that is in the hospital.
Yes. The doctor. Okay, health workers. Health workers. Okay, I was stealing them.
Yeah. So you'll be happy. No, but you see, I want him to be also honest about the reforms that have happened at NMS. That you see these drug stockouts that he's talking about. If you're talking about 50%, you get, we have come from a worse position. And as you can see, there will be drug stockouts, but it won't be a crisis. You know, we are now in a crisis because of issues of someone releasing money, others not releasing a system or whatever it is. Yeah. So there's been progressive, and I can tell you the number of days it used to take back in the day to get this medicine from NMS, it has changed. The amounts of money that are getting into NMS have drastically improved, right? So for me, it's a thing of we have an issue about governance and administrative issues in this country, competence of individuals who lead these institutions. That's where the issue is. But as far as things being done, a lot of things are being done. A lot of things are being done. About my last and final remark about drug stockouts reminds me of the issue of electricity in this country.
Yes.
Back in the day, used to load shed us.
UEB.
Load shed you for a day, two, you know. Today they load shed me for an hour. I am calling Umeme to abuse them. You know?
Yeah, but you see,
and countries, even far greater than us, the economic size. So the question shouldn't be really about money.
But you see, Isaac, I think we should not treat serious things casually. You know, we need to go deep and you know, look at the implications of not having those medications at the hospital. We can't say, you know, we shall have stockouts and it's okay. No, we need to go deep and look at the implications of not having those. For example, imagine you go to emergency units and you don't even have.
You don't have gloves.
I agree.
That's what I say. The priorities of the government. It should be like we are about to go into a budget. Yes. Government is in a budgeting process. In my opinion, the priorities should be security, and then after security, health of the people, and then educate the people. Yes. Isn't it?
Yes.
But it looks like our priorities are really not very clear. Maybe let me say that.
And I was trying to explain to him that, look, yes, fine. What you need to understand again. don't
because
look,
just
don't
imagine
look at our healthcare system
yes
from a government point of government aspect only. That the whole healthcare system as it is involves private and government.
Yes.
In the absence,
government has oversight.
Wait, let me. I'm going to protect. I'm going to protect Isaac now.
So
You'll have an opportunity to.
When you look at it in totality, yeah, there will be pains, and I've told you when you're a government contending with access to healthcare, vis-a-vis quality to healthcare, you get it. There are certain compromises you're going to make, as now he has stated that access should now, is it still a major issue? Should we still be investing money in brick and mortar? You get? So now we should now shift. Is our problem doctors' pay, yeah, or medicines, or gloves, and So it's that intricate balance that government must address. But the way my colleague here is talking, it's like government is a perfect institution, or should be a perfect institution, to sort out everything and
at once
and anything. You get it? So you have, for example, today, I don't know, this week, Uganda Cancer Institute was launching bone marrow treatment, whatever it is, treatment for cancer patients, fully funded by the government of Uganda. Fully funded by the government of Uganda. But they will not tell you what it costs to do that, right? So you have to look at it and say, okay, we have these issues, right? Uganda Cancer Institute was taken out from Ministry of Health and was given its separate vote, right? Uganda Heart Institute, the same. But when people go to the Uganda Heart Institute, they fork out money from their pockets to support. A bed in Mulago Heart Institute will take you about 200,000 a day. In Nakasero, you are looking at 5 million. But what are you looking at there? Government is spending money for the same person with the same problem. So when you look at it from the emotional thing of, what, there's a bad mattress. Those pictures probably they have put for you.
Yes.
You then miss the aspect of government which is financing bone marrow transplant.
Okay. Thank you very much. Thank you very much. I'm going to now. We are going into the final round of this talk show. So I'm going to ask, starting with Joanne here, for her to give us her closing final remarks on this issue as we wound up the show.
Thank you, Daniel, and it's exciting that we all speak with passion. When you stand in the space to defend government, it's always a hot seat.
Yeah.
So, Doctor, but we are together because as implementing partners, we want to see that collaboration, that continued platform where we have space to really discuss and see how to move certain agendas forward. So when we come out to ask questions, we really are to get answers, but also how to agree on how to move together jointly as the country. So with that said, I just want to end by saying that still commodity security or security for essential medicines and health supplies as one of the key health blocks is still very essential to us as a country. We are very aware that Uganda has just launched the 10-year roadmap for our supply chain. It's a very beautiful roadmap, and it really stipulates some of the areas that we are all interested in having as a country. So if we implemented this 10-year roadmap to the later, I would think most of the gaps that we are speaking to, that we really attribute as factors that are bringing gaps in the supply chain, will be addressed. And again, we have also just ended discussions, and we really appreciate that we are involved as civil society. There have been revisions of the essential medicines and health supplies list, where other essential medicines and supplies have been included, like essentials for COVID-19 that has not previously been in that key essential medicines list, but also the clinical guidelines. These are very key documents that have been updated and really still need funding to be implemented. So as implementing partners, we are here to work with you, but again, as we work, we need answers, we need transparency, we need accountability. The only way we can achieve this is through giving us a platform as government to deliberate on these key issues, and also come in and say, as implementing partners, how can we support? We are the immediate faces to the public. How do we lay information to the public? But which kind of information are we giving out to the public? So when we talk about risk management, we know that there are key policies in terms of risk communication in form of such a crisis, but we cannot come out to speak out when we do not have clear guidance from the different key entities that are at the forefront of such a crisis at country level. So let's have conversations. We are here to work with you as civil society, and we are here to really, we are in the community, we are in the districts. Like my colleague alluded to, redistribution mechanism at district level. As HEPS, we monitor stock statuses at facility level, and we use those reports on a monthly basis to inform redistribution. But again, we are not everywhere. Though the members on the Uganda Coalition on Access to Essential Medicines, we have placements, we have presence in most of the districts. We have programs that are in all the regions. So let's use our presence, let's use the physical presence of the civil society to reach out to communities, but also provide the correct information on what is going on and how do we man, or how do we really own up this crisis, but also provide sustainable solutions. So basically, as HEPS Uganda and the civil society community, speaking on behalf of the Uganda Coalition on Access to Essential Medicines, to the government of Uganda, we urge that you come out to provide clear information to the population. Let us know on how to handle this crisis. How do we live with it? If I've missed 5 months of treatment, how do I manage? How do I go back to care? And what does that mean? Is there clear guidance provided to our health facilities, to the health providers? Let's have this information on how to really address the risks involved in accessing care. And then to the different entities, national medical stores, of course, finance. If we could have conversations, if possibly have dialogues between these independent bodies to ensure that these administrative and operational issues that we are calling petty, but actually causing severe impact in terms of availability of these key essential medicines and health supplies, come on one table, but also agree. We know there have been discussions going on, but coming to really agreeable strategies that are going to really be lifelong sustainable solutions, not a 1 week to week emergency response and then we relax and sit back. Solutions that are sustainable, solutions that are reliable, but also that are going to be integrating a rights-based lens as we really address this. Knowing that as you are dialoguing, there are people dying, there are people there are people who are resistant to treatment, there are people who are on really failing treatment because of these interruptions in the supply chain. Then to our subnational players, the district stakeholders, I would urge that as we are advocating for policy shifts from the pull and push, let there be deliberate efforts to have clear inventories. If you have a chance to have procurement plans, let them be comprehensive enough, that our district kits should be good enough and address the timely needs of the population that we serve. Thank you, and it was nice interacting with you.
All right, thank you very much, Joan. Peter, your final remarks on this as you say bye-bye to the show and to the panelists.
Now, listening to Isaac reminds me of the idea that there are more than two sides to the argument.
Yes.
But then the question is, which side of the, which of the arguments is more rational? And I think Isaac would make a very good pair with this ability to flip the arguments on the other side. So I think it is critical that when we, especially general service delivery, including health education, I think we need to move conversations from politicization to just having this conversation about health service delivery. Because the moment we seem to make it political, then it begins to look like the opposition are castigating the system, the NRM is doing this. I think we need to have honest conversations on where is the problem, what is not happening right, and have that conversation as Ugandans, not as members of FDC, not members of NRM, not
because anyway, the malaria parasite doesn't know which party you support,
absolutely.
right?
So that conversation must be honest, but also based on the facts that we have. Actually, this country does a lot of studies on our health system. And if we use science to make decisions on how do we provide health service delivery, we would really do well in getting solutions to a lot of these problems. But you know, in this country, we want to appeal a lot to our political leanings. We want to appeal a lot to our religious leanings. We want to go to our cultural leanings. When you talk about sexual and reproductive health for young people, religious leaders will tell you, what the hell, what are you talking about? Young people are not supposed to be having sex.
Yes.
But then they're getting pregnant and all the things. But they're saying, no, that's not issues that we should have a conversation about. So I think as a country, we need to go back to evidence-based planning. Let's stop getting emotional about those other feelings we have and concentrate on dealing with a big problem. I am happy that the Prime Minister established a committee. And I think she was wiser than Parliament was. Maybe because of the visit, because you know, most of last year she visited quite a number of health facilities. If I remember my count well, she has visited more than a dozen health facilities over last year. And for her, she has said, I am putting in place a committee to look not at this stockout that has just happened, but to address ourselves to what is the problem with drug supplies overall, not just to look at what has caused this specific one. So I think it is a good thing. We need to go back to the drawing board and look at what exactly is the problem. There are lots of problems there that are beyond some of the things. And there is one of the things I expected the Parliament to have discussed about the drugs, beyond their mandate of looking at how much money they allocate and all that. But there needs to be an audit on the drug sector in this country. Not by politicians, but by technical people who understand drugs. I remember, I think in 2015, Auditor General attempted to do an audit on drugs. To try to establish, are we anyway getting value for money when we procure drugs? Because I have talked to DHOs who tell me that, you see, if you gave me money and you sent me to William Street, I'll actually buy more drugs with this money than NMS is supplying us.
At the same amount?
At the same amount. And of course, the issue of the breaking off of Uganda Cancer Institute can prove that. Uganda Cancer Institute. You remember previously they had battles with the NMS over the cost of buying drugs for them and all that. So when they gave them autonomy and they started buying drugs, NMS buys almost twice the drugs they used to buy with the same, Uganda Cancer Institute. So it is a conversation that this country again needs to have. Can the Auditor General do an audit to establish the money? Because the idea of creating NMS was that if we pull all the money we need for drugs from all these health facilities and districts, we will benefit from economies of scale. Having one entity procure a lot of drugs at one point. Is that still effective? Are we still getting drugs at a cheaper price? Because we could be actually losing a lot of money in this process, especially if we look at the example of Uganda Cancer Institute. So it's probably one of the conversations we need to have about drugs. We need an audit on how we get drugs.
All right, thank you very much, Peter. Dr. Asaf.
Yes.
your final remarks on this. I hope your final remarks will not be a jab to Isaac. You guys need to shake each other's hand.
Isaac, I'm sure I appreciate the fact that we understand the steps that have been taken by government, and we appreciate. And also, you know, unless we want to reinvent the wheel, we already have, as they've already said, institutes that are performing with a lot of, you know, effectiveness and efficiency, right? So what I'm trying to say is we can't sit down and accept that level of inefficiency from the people we entrust, you know, to run affairs on behalf of us. So at least let's push them, and we see how they can do maybe the best. But me withdrawing and saying, no, they have performed very well, you know, these challenges. Isaac talks about a legal framework. It is a stumbling block, but I'm telling him, you know, that the laws are not written in stone and concrete. And if we have laws that don't, you know, that do injustice to our population, then they are useless. And we have parliament and we have powers to repeal and repress them. And then my second submission, and the very last one, is I request government and Ministry of Health to really honor what is crystal clear and what they pledge to us, allowances for the senior house officers. Thank you.
All right, Isaac, you'll have the final say on this.
Yeah. Finally, I think for me, my take from all this, of course, like I said, we are spending very little money in terms of our healthcare by virtue of having embraced the desire to have free medical healthcare. But we have certainly realized that we can't afford it. Health insurance is the way to go, and I think the government must take this on, you know, a little more enthusiastically. The healthcare system, how we finance our healthcare system, should be now top priority going forward, because we can't afford it. Healthcare is the most expensive, I think, public service good that every country, you know, grapples with. And given our level of development, I think we need to find other mechanisms in which we finance our healthcare, and health insurance will really sort that out. About doctors' remuneration and all that stuff, I mean, to be honest, allowances and everything, it's going to be an issue for a long time. Government makes pledges whenever the crisis comes as a way to get these people back to work. But the channels and realities of their pledges, yes, you make a pledge, but there are things, the president has pledged roads for 15 years, they pledged the same road, the next budget tell you they don't have. The idea that government meets its obligations and when it commits should also be weighed in tandem with the realities. We were not facing inflation 2-3 years ago when they signed this. Now it's a big problem. You were not spending money, you were spending money promising people salaries. Ebola came. So what do you do? Recently, this week, I think the Minister of Health was asking for $35 million that the international bodies are saying as a way to, that's about, I don't know, 100 billion plus for Ebola Ebola aftermath, you know, I don't know, whatever it is that they are asking. So you see that the challenges keep changing. Yes, I have signed the thing, I'm going to pay you so much. Okay, the next day there is a war. Okay, what do I do? You know? So the most difficult thing really is that the government is facing very challenging times. Unfortunately, the people who offer some of the services don't want to know. You know, they don't want to know. And they are making their demands and they want them. And maybe government will fulfill them, maybe. We have seen wastage in government of resources. That's, you know, it's there, we can't hide it. But like I said, or maybe the listeners who are telling me about being insensitive to doctors, please, I'm very cognizant of the service that they provide, but surely it can't be money all the time. It can't be money all the time. Yeah, thank you very much for hosting me this week, and I hope it's a better discussion.
All right, thank you very much. Thank you very much. Isaac Kayonde is a political analyst and also an NRM mobilizer, and he's a former candidate for Gomba West. Yes. Then Joan Kirande, Health Policy Advocacy Program Manager at HEPS, which is the Coalition for Health Promotion and Social Development, and also a member of the Uganda Coalition on Access to Essential Medicines. Thank you very much for joining us. Dr. Asaf Owamukama Eli, former president of Senior House Officers, thank you very much. And this week we're going to be covering a lot of the Senior House Officers because they have gone on strike starting today. You heard it here first. The strike has been announced, so they'll be laying down their tools. Peter Echeru is the program coordinator for advocacy at the Center for Health, Human Rights and Development. Thank you very much for joining us today morning. Thank you very much all our panelists and all the people who are watching and listening to us on Twitter Spaces and on YouTube. Join us next week at the same time for another interesting viewpoint and many other viewpoints from the various panelists that we'll have selected for you that time. My name is Daniel Lutaya. Have a good afternoon. Bye-bye.